Hello, everyone, and thank you, and welcome to Oceanside Library's afternoon program, Oh, My Aching Joints, an Arthritis Seminar. This program is brought to you by Assemblywoman Missy Miller's office and Northwell Health. Before we begin, I just want to let everyone know that Assemblywoman Missy Miller apologizes. She cannot come to the program today because she's on an important call with American Water to help us solve that problem in the county. So our presenter today is Dr. Michelle Lobo, clinical rheumatologist and assistant professor, Division of Rheumatology at Northwell Health. So welcome, Dr. Lobo, and thank you for being here. And when you're ready, please start the program.
All right. Hi, everybody. Thank you very much for having me. And I hope that, this presentation will give everybody a nice little overview of the different kinds of arthritis. And at the end, we'll definitely have time for questions. Okay. So let's begin. So just quickly, I don't have any disclosures, not currently working in any sort of research capacity or with any pharmaceutical companies. So quick overview.
Can't hear anything you're saying.
Hi, please mute your microphone and sorry.
Can everybody hear?
Better.
Okay. I'm going to try to bring my volume up a little bit as well. All right. Any better? Okay. So arthritis is a term basically for joints that have a few different possible features. So they can be inflamed, they can be swollen, they can be painful, they can be red, they could be stiff. So there's lots of different kinds of arthritis that this encompasses, but the most important part of this is that it's one of the leading causes of chronic disability. So a lot of people think, oh, they're just my joints, I'm not going to pay attention to it, I'm not going to worry about it. But in the grand scheme of things, we actually know that arthritis really debilitates a significant number of Americans. And so it is worth talking about and just being aware of. So, like I said, we're going to go through a couple different ones. So this is basically what's happening with arthritis. It's pain in one or more joints, and a joint is anywhere where there's two bones meeting. So if you look at the little diagram here, you can see the two bones and you can see a little bit of a pocket around it. And in that pocket, there's some cartilage, there's some fluid, which acts as like a lubricant. There's a little bit of a membrane that protects it from infection, from the rest of the bloodstream, from the rest of the body, because we want to make sure that infection doesn't get into these areas. And then there's another barrier around it that kind of holds the joint in place. So this is kind of, as we go through it and I talk about some things, this is, keep this image in mind because this will kind of, we'll come back to it in certain layers. And this is why we should be talking about this. So 22.7% of adults will have doctor-diagnosed arthritis. Women, unfortunately, have a much higher incidence of having arthritis during their life. And a very significant portion of people who have arthritis will end up having limitations in their daily activities due to their arthritis. And that's really why we focus on it this much. And we can see in the little diagram here that we expect this number, unfortunately, to keep rising. So we know that, we have about 46% as of a little before 2005, projected is going way, way up. And this is the other important part to talk about arthritis. It's expensive and it has a lot of impact on healthcare costs. And basically part of this talk is also to help people have a little education, a little background on what they can do for their arthritis before they have to incur healthcare costs by going to a doctor, by missing work, all of those kind of things. So that's basically where, if we can give you guys a little more information and some troubleshooting points through this, then that's basically our goal. Okay. So this is the prevalence of just some kind of kinds of arthritis that I'm going to touch on today. So number one is osteoarthritis or wear and tear arthritis. This is what happens as we use our joints as we get older. So 30 million adults are currently living in the United States with osteoarthritis. Rheumatoid arthritis, which is a very common disease that rheumatologists like myself treat, it's actually not that prevalent. It's not a very common disease, about 1% of the population. So we're looking at around 1.5 million adults right now. Gout, more common than rheumatoid arthritis. So we'll be touching on gout and pseudo-gout as well. And that's about 3 to 6 million people in general when you take into account somebody who's only had one flare versus somebody who has lifelong gout. And just so, we're talking a lot about adults, but children can also get arthritis. We won't touch on that today, but just be aware that, children can also get different kinds of arthritis. And the last one is psoriatic arthritis or spondyloarthropathies, which are inflammatory arthritises that are usually just limited to your spine. And that accounts for another, 2 million or so people. Okay, so this we kind of talked about before, but the reason we're talking about this is it's a leading cause of disability. So when people do have arthritis, we see a lot of limitations in their day-to-day things that they can do, and the jobs that they can do, and the lives that they can lead. So we notice that people can't walk as much, and walking is a big exercise that, every doctor is going to encourage you to get some cardiovascular exercise to keep your heart strong, to keep your lungs strong, to keep weight down. When you have arthritis, it really limits how much you can do, and then it becomes harder to maintain the other areas of your health. Some people have a lot of stooping, bending, kneeling, either at home or in a job setting. That also can become very difficult to do. And climbing stairs is probably one of the things that we hear the most complaints about. People can walk, on a flat surface without too much issue, but climbing stairs, and a lot of people have a lot of stairs in their houses, becomes a real issue. And social activities. You worry, can I go to this place because I have to climb these stairs, or I have to walk quite a distance from where I parked my car to get to this place? That limits us. And finally, just in general, in your day-to-day, how you feel, how you think, how you're able to get things done. Pain is something that really limits the quality of life that we can have even in a 24-hour period. So when we ask people who have arthritis chronically, how have you been in the past month? They report many more unhealthy days where they weren't feeling well compared to patients without arthritis. Okay, so how many different kinds of arthritis are there? A lot. And I'm not going to bore you with every single one of them, but I basically picked a couple of the more common ones that we can discuss today. So here are the ones that we're going to touch on. So in the inflammatory arthritis category, we're going to talk about rheumatoid arthritis and psoriatic arthritis, because those are the two most common. We're going to skip entirely over the lupus myositis ones because we very rarely see those. We're going to spend a lot of time on osteoarthritis because that is by far the most common and the one that, as people in the community, you can actually do something about before you have to come to see a physician. We're going to touch on gout and pseudo-gout because, again, very high prevalence, and there are some things that we can work on before you come to see a doctor for that. And then I'm just going to quickly touch on infectious kinds of arthritis. Lyme is probably the most common, sometimes bacterial. So osteoarthritis. So this is the most common, and the other names that people may call it are wear and tear arthritis or degenerative arthritis. The idea behind it is it's an arthritis that basically happens as we age, as we use our joints, as our joints wear down. So if you remember back to the first screen of the joint, there was a little bit of a layer of cartilage. And that's basically what starts wearing away in osteoarthritis. And that's a cushion. And that helps the bones kind of glide easily past each other. So when that cushion goes away, you can develop osteoarthritis. So the most common places are in weight-bearing joints. So we're thinking hips, knees, the spine. Okay, it's also in repetitive use joints. So I get a lot of patients who will come to me and go, my thumbs really hurt, but they're like, well, I'm not walking on my thumbs, but we use our thumbs a lot, and we use our thumbs for all sorts of different hand motions. So we actually end up using our thumbs in general much more than any of our other fingers. And so the thumb joint will often wear down and you'll have osteoarthritis there. Sometimes shoulders can happen as well, especially with people who do a lot of heavy lifting and things like that. And finally, the fingers can also be affected. And if you can see my arrow, these areas here are the DIPs, and then the middle set of knuckles are the PIPs, and those are the ones that are most commonly affected. This big set of knuckles up here usually is completely spared. So just going through these pictures, this is a knee. This is a more normal knee. This is an osteoarthritic knee, and you can see that it's larger. There's some deformity. It doesn't quite look as even as the other side. Over here is a hand with DIP and one PIP involvement, but the rest look pretty normal right now. And if we were to x-ray this hand, this is what we would see. And we'd see all of these white changes where the bones look very close to each other and very irregular. And that's basically what's happening because the cartilage cushion is gone. Okay. So the big question, how do I know if I have osteoarthritis? So these are a couple of questions to ask yourself. Do you have pain all over a specific joint, all through the day, or with certain kinds of activities? So if you notice, I have knee pain only when I'm climbing stairs, but I can walk on a flat surface, that may be knee osteoarthritis. Or you notice every time I get up from a seated position, I have pain, but then once I start walking, it goes away. May also be osteoarthritis. You may notice that when you sit down and you rest it, it gets a lot better. But the minute you get up again, you actually feel like the joints are really stiff. And then within a couple of seconds, it loosens up. So this is a phenomenon that we call gelling, which if you kind of think of something like a Jell-O that's in liquid form when you first make it and then it sets, that's kind of the idea. So our joints are constantly moving back and forth between ease of motion and a little more set. And so when we sit down, you're going to get a lot of pain relief, but the minute you get back up, you may feel it for a couple of seconds. And that's normal. That's just how our joints function. But a lot of people get very concerned that that may be, something that's indicative that something's abnormal. A lot of people will say, hey, I can feel it when a storm is coming, or if it's going to be humid out tomorrow. That's actually true. All of our joints act like little barometric pressure sensors. And that's why when that cartilage is gone, there's more air in there. And when the pressure changes, that's why you guys have probably more of a heads up on the weather than the weatherman. And lastly, if we were to look at x-rays, we would see
Join the meeting.
a lot of changes. So this over here is a normal, and you can see a very nice space between the two bones. And over here is an arthritic joint, and you can see that the space between is gone, and that's where the cartilage would have sat. You can also see a lot of white. You can see these little jagged edges on the side, and those are basically all of these words that I have down here, which you would basically see if you got your x-ray report and you said, hey, I want to look at this by myself. So what causes this? So we know that increased BMI for one's weight definitely increases your risk at any age. So if you have more weight on your body than your height can support, your joints end up taking a lot of the pressure for that, and that can accelerate the cartilage loss. As we get older, we've been using our joints longer. So that again accelerates cartilage loss. Some people, especially athletes or people who are doing a lot of heavy lifting or walking during their jobs, things like that, will have accelerated arthritis from overuse. Some people will have previous damage, meniscal tears, ACL tears, things like that. Anytime the joint is not completely stable, we can have some cartilage loss. And then the last thing, which is something we don't often think about, but if you have some sort of mechanical imbalance that's been through your life or something new, so legs are slightly different lengths, or you've been limping for some reason, or you have a history of scoliosis from when you were a child, or you've had a stroke and you've got muscle weakness on one side of the body. All of these things may cause you to hold your body differently. And then the joints that take more stress may wear down faster than other ones. Okay, so what should you look for? So these are the big things that you can look for yourself and see, could this be osteoarthritis? So we're looking for bony enlargement of joints, but you won't see any soft tissue swelling. So if you look at these pictures, this is somebody's thumb, and we can see that the base of the thumb is very prominently sticking away from the wrist. Same thing over here. This finger here looks normal, but then over here we have these really big nodules forming, and that would be evidence of osteoarthritis. Crepitus is what doctors call this kind of crinkly sensation that we feel when you move a joint. So most people will hear like a cracking or a popping. I usually liken it to feeling like there's bubble wrap that's popping inside of your joint when you move it. If that happens consistently, that often is an indicator that there may be arthritis in there. Not everybody, though, who has that cracking or popping is going to have arthritis. Sometimes that's just little air bubbles. But if it's that combined with pain, combined with limited range of motion and things like that, then we may be dealing with osteoarthritis. Sometimes you can get fluid in the joints. So you'll almost have like a water balloon-like feel if you were to press on the affected joint, but there shouldn't be any warmth. So it shouldn't feel warm to touch, kind of like you have a fever in that area. If anything like that is happening, we'll talk about that later, but pretty much you need to go see a doctor to get that checked out. And then at the end, you may have joint line tenderness. So if you press over the painful knee or you press over the painful finger on the sides, that may be intensely painful, whereas if you press from front to back, it's often not as painful. And that's because on the sides is where the joints actually hinge. And so that is usually the first place for the arthritis to be affecting you. So here are just a couple of pearls because sometimes it's hard to tell exactly what's going on. So our bodies are a little bit strange in terms of how they always display certain symptoms. So hip osteoarthritis actually will be pain that radiates to the groin, not on the outside of the hip. So if you have pain on the outside of the hip, we're actually more so thinking, is this coming from your spine? But if you have groin pain every time you walk, that could very well be hip osteoarthritis. Knee osteoarthritis may actually go up your leg and be felt on the side of the hip, or sometimes it could be at the back of the knee rather than in the front on the sides. And then spinal osteoarthritis, you may not feel true joint pain in your spine, but what you may have is a lot of muscle spasm, a lot of cramping. People will say your muscles are really tight and things like that. And oftentimes that's an indicator that there may be some underlying arthritis there. So we talked about the effusions, which is the water balloon-like feeling. Some people, when they see something like that, they automatically get really worried. This is gout, this is rheumatoid arthritis, this is something that has to be drained. And oftentimes osteoarthritis can have a little bit of fluid buildup, but it's benign, usually doesn't have to be drained. And we actually recommend against drainage because usually it comes back. So we don't want to put a needle in, cause you pain, all of that, basically not to get any benefit for you. And the pain can be all sorts of different kinds of pain. Some people will say sharp pain. Some people will say dull and achy pain. Some people will actually have nerve-like pain where they'll feel like almost like a tingling or a numbness or something like that. But it should only be over the joint that's bothering you. It shouldn't be kind of all over the body. And I just briefly want to touch on erosive osteoarthritis. So this is a slightly different kind of arthritis. And it's very similar to regular osteoarthritis, but it tends to be in middle-aged women more so than it developing later in life, like 60 and older. These patients tend to show up in their mid to late 40s, early 50s, but they'll have hands that look like arthritis from a later decade in life. And they'll have these extreme areas of swelling and bony formation. So oftentimes there's actually a familial link here. So if you have hands like this, think back. Does your mother have hands like this? If you have sisters, do they have hands like this? There may be a familial link, but it's actually arthritis, osteoarthritis, just like other kinds. Okay, so here are the things that you can do before you have to get to a doctor. So pain control, probably my favorite because it doesn't have a lot of side effects, is Tylenol. And you can comfortably, for most people, as long as you don't have liver issues, you can take Tylenol arthritis, and that helps, with about 8 to 12 hours worth of coverage, and you could take 1 to 2 pills twice a day. So that's fairly safe. It doesn't increase risk for stomach bleeds or anything like that. If your doctor is okay with you taking NSAIDs, and that isn't everybody, you can take some NSAIDs, but this I always say clear with your physician first, because these medications do have side effects, from bleeding to putting stress on your heart and blood vessels. So it's not something to just take lightly. And if you find that you are taking it fairly frequently, speak to your doctor about it. My new favorite thing is Voltaren gel, which some people may have seen over the counter. So we used to give this out as a prescription medication, and I think eventually it was found that it was fairly safe to use, and a lot of people really liked it. So it's in the same family as other NSAIDs, Motrin, ibuprofen, Advil, Aleve, but because it goes on the surface, it has less of those side effects that I just talked about with taking the pill versions. So in some people who can't be on any sort of pill NSAIDs, this is a nice way to just put it on their joints, and it helps a little bit. And then there's also other topicals, so capsaicin cream, heating pads, icy hot, things like that. A big thing that we always tell patients is do not stop moving. The pain will want to make you stop moving, but the more we move our joints, the more we nourish our joints, and the more range of motion that we maintain. So keep trying to do things. You don't have to push way past your pain limits, but if you can do light activity, keep going. If you can walk a couple steps and then you need a break, do those couple steps, then take a break. And sometimes what you can do is you can strategize when you're taking your pain medications to when you're exercising. So if you take your Tylenol 30 to 60 minutes before you're going to head out for your walk, you maybe have better pain control while you're walking and be able to get further, and then you're continuing to do good for your joint. And if people are comfortable in pools and have access to pools, aquatic exercise is wonderful because it takes the stress off of the joints, but allows you to continue exercising. And a big thing that a lot of docs will always say is weight loss. And we actually have data for weight loss with osteoarthritis. So we know, for example, that 10 to 15% of your current weight lost can actually offload your joint by more than 10 or 15%. So it actually is an additive benefit. You get more for how much you put in. And in the long term, we also know that this results in less pain, less progression, overall maintenance of range of motion. So this is something that's very doable without a doctor and has a lot of payoff. And lastly, if it's more of the spinal arthritis with spasm, stretching, yoga, things like that can be really, really beneficial. Okay, so when to get to the doctor and what to expect. So you may start off by seeing your primary, and your primary may refer you on. So if you're going to come to a rheumatologist like myself, or an orthopedist perhaps, because we often have some overlap, oftentimes the first thing we're going to offer you is physical therapy. And that's just basically all of the things that I kind of went through on the page before, but in a more guided setting with a therapist who can kind of determine the best plan forward for you. Next step, we can sometimes consider injections. So either cortisone injections or gel injections, but we have to be mindful that these are good for moderate arthritis, but once we get really severe arthritis, they start to not be as effective. There's also medication options. So sometimes we'll use, and these are a couple, Cymbalta, gabapentin, or prescription NSAIDs. And in some people who have a lot of arthritis, it's not feasible to give them, 10 different joint injections. Physical therapy is not an option, or they've tried physical therapy and it hasn't helped them. We can put people on medications, but we usually reserve that for later because we don't like to add extra medications if we don't need it. And just of note, if you have hip arthritis, oftentimes that requires you going somewhere else for the injection, whereas a lot of the other injections we can do in an office setting. So surgery, lots of replaced joints these days. And that's an indication if you haven't responded to any of the above treatments, or if you have really bad arthritis on imaging, you can't really walk very far, you have fluid that just builds up over and over and limits you. But that comes down to, does the surgeon feel that you would do well with the surgery? And can you kind of rehab around it? So basically, we have to be cognizant of the fact that it's not just the surgery, but being able to do physical therapy before and after. And then the last doc somebody may send you to would be a pain management doctor. And they, especially if you have a lot of arthritis in your spine, they can do local epidural injections, or they can sometimes do trigger point injections, but I find that those are not as helpful. Okay, so that's the end of osteoarthritis. We're moving on to what we call crystalline arthritis, or gout and pseudo-gout. So this is just a little side-by-side comparison. So gout is the far more common. It's these very long rod-shaped crystals that end up in the joint space. We commonly think of it as the big toe arthritis, but it can involve a lot of other joints. And we do see it sometimes linked to diet, sometimes linked to medications, tends to be more so in men, but postmenopausal women can also get it. And it tends to recur. So that's kind of, people with gout often have this as a lifelong issue. By comparison, pseudo-gout is a different kind of crystal. It's a calcium crystal, these little rectangular shaped crystals. It tends to go for the knee more so. It tends to be seen more so in women and more often around times of people getting sick. So if they're in a hospital setting, or they've been put on antibiotics, or there's been something that's changed with their medications, those are the times we may see pseudo-gout. And the good news here is it tends to happen once for most people. So most people don't have recurrent pseudo-gout. So just a couple things to look out for. So especially with gout, people may notice that they have repetitive episodes. And oftentimes certain foods will trigger it. And everyone's different, but these are the big triggers: red meat, shellfish, beer, alcohol, and sometimes fructose. People who have high blood pressure, who are on aspirin, who are on water pills, who are in kidney stone, who have kidney stones, who may have diabetes, they all may be at a slightly higher risk for gout. Now, I never say don't take aspirin, don't take your water pills. Gout is something that we can treat, and oftentimes these other medications are for life-saving reasons. So we will always work around the medications to treat your gout. Sometimes people will give young people diagnoses of gout, but it's extremely rare in premenopausal women or men under the age of 20. So usually that's not gout. And what you're looking for is a joint that gets intensely painful, intensely warm, very red, very swollen, very quickly. So within less than 24 hours, you suddenly go from being able to walk to not being able to put any pressure on that big toe. And some people will actually develop fevers. They'll have a little bit of a white count. It'll almost look like they have an infection, because gout will actually kind of create almost like an infectious process when we check your blood work and your temperature. This just causes a little bit of confusion, so I just wanted to touch on it. Our uric acid levels, oftentimes we'll check them and we'll say, oh, is this, in line with you having a gout flare or not? Just letting you know that the uric acid can be normal during the time of a flare. So it doesn't take away the concern for gout, but if we see it high while you're having a flare, it just helps us make the diagnosis. And also sometimes your doctor will also check other labs, especially if it's your first episode, kind of looking for a reason as to why this is happening. Okay, so this is kind of the thing that we touched base on earlier. So the joint will be warm, it'll be red, it'll be swollen, can't tolerate light touch. A lot of my patients will say, I can't even have a sheet over my toe when it's happening. And sometimes you'll see swelling in the remainder of the foot. So the toe may be intensely painful, but the whole foot gets swollen. And that's what we call sympathetic swelling. So that doesn't mean that you have multiple areas of gout, but that's just because the gout is happening in the toe. Sometimes people will also get this kind of rash towards the end of it as their skin kind of starts peeling or flaking away. that's normal, and that's just the process of the gout clearing out of the system. And the last piece, which is something that people don't often see, is things called tophi, which are little areas that the gout crystals have started depositing in non-joint spaces. So I put a couple of pictures up here. So we have a big toe that looks like that, maybe a bunion on there, but actually you can see it's a little bit red, and bunions usually shouldn't be red like that. And so that's actually a gout crystal deposit. And then this is a fingertip, and sometimes it'll deposit in the pads of fingertips. And the one other thing that docs may do, especially if we start talking to you and you're saying, oh, you know, I do have my toes get really painful, but it's never so bad that I can't walk on them. They're just irritable and irritating for a couple of days and then they go away. If that happens frequently enough, a doctor may say, let's just look at an x-ray of your feet, because not everybody has the classic severe pain, can't walk kind of flare. Other people will have very mild flares, but then when we do x-rays, we actually see that you've been having gout all this time. All right, so how can you treat this at home? So if your foot is affected, you can raise and elevate the foot. If it's another joint like a knee or an ankle, try to avoid overuse until it starts to get better. You can use ice packs, cool water, but avoid heat because heat tends to make it feel just worse. If your doc is okay with you taking NSAIDs, you can absolutely use over-the-counter NSAIDs, up to 1 dose 2 times a day. Just make sure you take it with some food to protect your stomach. And if your doctor has prescribed it, colchicine is sometimes used for people, especially with recurrent gout flares. And this medication is best if you take it within the first 24 to 48 hours. So if your doctor has given it to you, don't wait for 3 days before you take it, because by then it's probably not going to be effective. If you have it at home for a gout flare, try to use it quickly. It usually does its best work within the first 24 hours. Okay, so now you've had a lot of gout flares, you've tried all the things at home, you ended up at the doctor with a diagnosis of gout. So the first thing we would try to do again is NSAIDs, but prescription strength ones. And these are a couple of the options that you may come across. Colchicine, again, is something that we often give, especially if people have repetitive flares. It has less side effects than the NSAIDs, but does a pretty good job as long as it's taken quickly. So I do tend to offer this to my patients who I worry about having flares. Depending on the severity of your flare, some doctors may give you steroids, either a Medrol dose pack or prednisone. There's no right or wrong answer here, but if you come off of a Medrol dose pack that your doctor's prescribed and you have another flare very quickly, the next time around, it may be better not to use a Medrol dose pack and use a lower, longer dose of steroids. And the one thing of note, if you have diabetes, this is a time when you should be watching your sugars very closely because steroids can make them go up. And sometimes, depending on how many joints are involved, if you only have one joint involved and you have diabetes or you have other medical issues and we don't want to give you a medication that's going throughout your whole system, we may say, let's do a steroid injection. So we'll actually inject only the affected joint, and that leaves you with the least amount of potential side effects. Okay, and then we also have long-term treatment. So if you have multiple flares, 3 or more in a 12-month period, we know you have kidney stones, or we've seen those tophi when we examine you, we see x-ray changes, or we know that every time you get a flare, you are down for the count for a week and you can't move, and we feel like this is really going to keep happening, we will give you long-term treatment. I just wanted to go back to the high uric acid levels. Sometimes we'll ask, the doctors to check a uric acid, but you've never had a gout flare. If the uric acid is high, but you've never had an actual flare, we do not recommend medication because, again, the side effects outweigh the potential benefit. So here are a couple of medications you may have seen or heard of. One is called allopurinol. The other one is called Uloric, and these really help us to decrease our risk of having further flares. So with allopurinol, it's probably the one that we use the most, and it's got a really nice range, so we can start you really low and we can kind of figure out together how much of a dose you need. And we'll often use colchicine to help prevent flares when we start it. So sometimes people will say, well, why are you giving me a medication that then is going to create a flare? When we first start these medications, they can create flares, but in the long term, they actually do a very good job of stopping flares almost entirely. The Uloric is a newer medication that we have. It's a little easier in terms of dosing, and it's a little better for patients with kidney issues. And so we do have that available, but we are a little bit more careful with it because we know that there are some heart disease risks. So most people will offer allopurinol first if a medication is being discussed. And then finally, going back to that colchicine that we're adding on when you first start either of these medications, the plan is once we get you on a stable dose of the medication, we'd actually take this away. So yes, you're starting with 2 meds, but eventually the hope is that you just come out of this with 1 medication. And this is just a quick picture of what gout can do. So I'm just going to show you this area right here, where you can see a little chunk taken out of the bone here, some irregularity here. And a big chunk right in here. So this is somebody who's had probably multiple episodes of gout over quite a period of time, and it started to destroy their bones. And that's really why we treat so aggressively, because we want to make sure that people's joints stay intact. Okay, so pseudo-gout, just really quickly, this is the other kind of crystal, the calcium crystal. And again, this is most commonly seen with infections or if medications have changed or things like that. It'll go after knees more so. And oftentimes you won't really have a history of recurrent flares. You'll be totally fine, or at most you'll have a little osteoarthritis, and then all of a sudden you have a swollen knee. Again, low-grade fever, white count looking a little bit like an infection can definitely be seen. The exam is very similar to gout, intense pain, very warm, very red. You don't want to move it. And the workup to be expected here, we often will look for infection, we'll look for your electrolytes, and we may get an x-ray of the joint. And the treatment is pretty much the same in the short term. So at home, you can try NSAIDs, you can try Tylenol, you can try ice packs, you can try colchicine if your doctor has prescribed it. We may give you prescription strength NSAIDs, colchicine, or steroids, but there is no allopurinol or Uloric. There's nothing to decrease the calcium crystals in your body. But the good news is we don't often need a medication because it's very unlikely to recur. Okay, so we're moving on to rheumatoid arthritis. So this is a more autoimmune arthritis, and this is a chronic arthritis. So it's not a very high worldwide prevalence, but it can be very debilitating, which is why we're talking about it, and something that to keep in the back of your mind if you're questioning what kind of arthritis do I have. So women are much more affected than men. And we do know that there is somewhat of a genetic predisposition. We see it much more consistently in identical twins who share 100% of their DNA compared to fraternal twins who are basically siblings who share 50% of their DNA. And the main symptoms are an arthritis, which I'm going to walk you through, and then a lot of actually other non-joint involvement. So we have a slide coming up, but just to get a sense that, we call it rheumatoid arthritis for a reason, but there are other organ systems that can be involved. Okay, so the typical rheumatoid arthritis patient will be a young to middle-aged woman, will have slow onset of pain and swelling and stiffness in symmetrical joints. So both hands, both wrists, both ankles, both sets of toes. And oftentimes this will be going on for a couple of months and gradually getting worse. Anything that's less than a month, unlikely, or it may just be too early. But once you've gone past a month, it's time to at least get to a doctor and say, hey, what do we think is going on? And some people will have a slightly different presentation. They'll have this migrating joint pain. So it'll almost be like a gout kind of thing, where you'll have one toe and then one ankle and then one knee, and they'll always usually resolve in between. So the toe will be intensely painful, gone in a couple of days, then the knee starts, gone in a couple of days, then an elbow starts, gone in a couple of days. But over time, it'll eventually even out into both ankles, both knees, both elbows. And then that kind of could be considered, is this rheumatoid arthritis starting? So if you think, could this be what's going on? These are the questions I want you to ask yourself. Do you have painful, swollen joints that when you press on them, they kind of feel like they're spongy? Do you notice limited range of motion, especially when making a fist? So this is a normal fist, completely closed. Some people can only bring their hands out to here because their joints are so swollen that it won't let them bring it all the way in. Do you hold your arms slightly bent at the elbows? Because if you fully straighten your elbow, it hurts a lot. And just remember, you may not have warmth or redness over the joints. You may just have a couple of these symptoms that I just went through, but without like a big swollen joint. So here's just a little diagram of a normal joint. So again, we have the bone and we have this nice little cartilage cushion. And then we have this little pink space on the sides, which is the barrier. That's both cells that help nourish the joint and also cells that help keep infection out. In rheumatoid arthritis, we see that this little pink line becomes a huge mass of cells. And this is where the rheumatoid arthritis is really affecting. It's creating all of this swelling and extra cell creation in this barrier that's supposed to be a very thin barrier. And eventually over time, all that pressure destroys the joint inside of it. And towards the end, it can actually start to look very much like an osteoarthritic joint. But in the beginning, we see more of the soft tissue, and that's where that sponge feeling that I mentioned comes from. When you press on it, you're actually feeling that swollen synovial membrane. So how does this happen to us? So we're not quite sure, but here are a couple of our working theories. We know that people who are smokers have a higher risk of developing rheumatoid arthritis. We know that people who have chronic untreated gum disease have an increased risk of rheumatoid arthritis. And we know that people who have certain kinds of gut issues like Crohn's disease, ulcerative colitis, or things like that may have a slightly higher risk for developing this. And what we think is it's a two-factor approach. There's some genetic predisposition, and then there's something that happens to us environmentally at some point in our lives that predisposes the genetic susceptibility to become a real disease. So this is kind of the workup you can expect if you come to a doctor really concerned that you have rheumatoid arthritis. We'll probably do some blood tests. We'll look for inflammation in your blood. We'll check rheumatoid factor and a CCP antibody, which are specific for rheumatoid arthritis, but there are people who have rheumatoid without them. And also sometimes if you come in too early in the process, we may not see antibodies, but they'll develop later. So that doesn't mean you don't have rheumatoid arthritis. It just means the antibodies haven't shown up. And you'll also be screened for other things. So we'll check you for other kinds of virals and infectious processes just to make sure we're not missing anything. And we may also get x-rays usually to start to look for bone damage. Sometimes MRIs or ultrasounds, but usually those are only if the x-rays don't give us the answers that we're looking for. And here's just a quick diagram of a progression from a mostly normal early rheumatoid hand to a very severe rheumatoid arthritis. And you can see loss of joint space. You can see a lot of these areas of white, which weren't there before. And finally, in the last one, you can see that the bones are very much on top of each other. They're very displaced from their normal places that they're supposed to be. And the wrist, you can see, has pretty much lost all of its definition. So this is what's happening on the inside as we're seeing all the pain and swelling and stiffness on the outside. And again, we think of this as primarily an arthritis, but we do have other symptoms that happen. And this is really why we take rheumatoid arthritis so seriously, because it can have a lot of different symptoms. And we're going to get into in a little bit, it can also have a pretty high risk of heart disease. So other organ systems that can be involved, we can see skin changes, we can see heart affected, lungs affected, eyes affected, nerves affected, blood counts affected, and finally the kidneys. So how do we treat it? So the first thing is probably with your primary doctor, you'll be given either NSAIDs or steroids, and you'll be told do some stretching, use some cool packs, things like that. Let's see how this works. If the NSAIDs aren't fully helping, or when you try to stop them, the pain comes back. If you're severe enough, the primary gave you steroids, or if any of your labs or imaging come back concerning for rheumatoid arthritis, your next stop is a rheumatologist. And these are some of the medications that we have on tap to give to our rheumatoid arthritis patients. So I basically split them into three because we have three different levels of medications that we can try. We have different kinds of options, injections, pills, things like that. The point of this slide is really to just show you that we have lots of different options, and there's lots of different ways to treat rheumatoid depending on the patient and the severity of the disease. And this is just a little bit of a chart to show the percentage of improvement expected compared to other medications. So we're always looking to compare our medications to each other to see which ones are superior, because we don't want to keep patients on medications that aren't as good, especially as we come out with new medications. So here's some frequent concerns that I get about rheumatoid arthritis medication. So number one, it's a chemo medication. What am I doing getting a chemo medication? So the answer is that we often will use medications that are similar to chemotherapy medications or actual chemotherapy medications, but our doses are very different. So we use tiny doses compared to chemotherapy doses. Another big concern is this is going to really bring down my immune system. You're opening me up to other infections. And that is a concern. That is 100% a concern. But the idea of this medication is actually as an immunosuppressant. So we know that rheumatoid arthritis is an overactive immune system. And so we're actively trying to bring it down so that your immune system stops attacking your joints. The other interesting thing to keep in mind is that the RA itself, if it's very out of control, it completely overwhelms your immune system. So even though your immune system is not immunosuppressed by a medication, it may not be working at full capacity. And actually, when we treat the rheumatoid, you actually have a better immune system than you had before. Another big question we get is, are these medications curative? And unfortunately, we don't have any cures as yet, but these medications do a very good job of inducing remission from flares, but they do often need to be taken lifelong. And lastly is, I can't inject myself. This is not going to happen. So just of note, if you're diagnosed with rheumatoid, if an injection medication is the recommended one, just know that we've come a very far way in terms of our injections. Oftentimes these days, it's all inside of a pen. You hit a button, it does everything else for you. There's no drawing up medications. We use a teeny tiny needle. Most people don't even feel the needle or the injection. And I just wanted to touch quickly on some of the long-term complications. So again, we think about this in arthritis, but it affects the liver, it can affect the blood vessels, it can affect the brain. So this is a much more all-over process than often thought about. And this is probably why we're the most aggressive when somebody has rheumatoid arthritis with treating you. The joint pain can be debilitating, but some people will say, I can live with some joint pain. This is why we want to treat you. We know that the heart disease risk with rheumatoid is very high. And so we know that it is in some cases equivalent to having diabetes, having metabolic syndrome, and the likelihood of having bad outcomes after a first heart attack or a stroke are much higher with rheumatoid. So if we look at diabetes compared to rheumatoid arthritis, we see that both of them are associated with arterial stiffening, carotid plaques, things like increased plaques throughout the body. We'll see the same kind of blood tests in somebody who has diabetes and untreated rheumatoid arthritis. And sometimes the lining of the blood vessels will also become very inflamed. So basically think about it as if a rheumatoid arthritis diagnosis is equivalent to a diabetes diagnosis and something that has to be taken very seriously. Okay, I'm going to quickly touch on these because I know we're running out of time. But psoriatic arthritis is very similar to rheumatoid, just with some slight differences. So I'm just going to really highlight a couple of the differences. So you're still going to have pain, swelling, prolonged stiffness. We call it psoriatic arthritis, and a lot of people expect to definitely have to have the rash, but not often. Some people will just have a family history. And the big thing to look out for is, are these joints really stiff, painful, swollen, and really for a long period of time, greater than an hour? So again, you're going to look for those spongy joints. Sometimes the tendons are involved. So you may feel like your joints really hurt. They don't look swollen. They don't feel spongy. And that may be a tendon thing that a doctor can examine and see. And sometimes you have a new rash. It doesn't look like characteristic psoriasis, but it's a new rash and it's happened over the same time as your joints have been bothering you. Or you've had more nail changes over the same time as your joints have been bothering you. And oftentimes that's an indication to at least have a doc take a look at you. And this is what to expect from a doctor. We'll order some blood tests, but it is a hard diagnosis to make with blood tests. We will possibly check the HLA-B27 test, and usually we'll order x-rays as our first image. Treatment, again, kind of consistent with what we would do for rheumatoid. Most of the time it's NSAIDs or steroids to start. And then our secondary medications are very similar to our rheumatoid arthritis medications. So there's often overlap. We use quite a few for both. And then there's also some other medications that are approved for Crohn's disease or ulcerative colitis in addition to psoriatic arthritis. And last but not least, infectious arthritis. So septic arthritis or infectious arthritis, we can see it in any setting. So this is probably the biggest thing that I want to ensure that everyone's aware of. You can have osteoarthritis, you can have rheumatoid, you can have gout, and you can still get an infection as well. So you're looking for one joint that's very painful, stiff, swollen, warm. Have you been diagnosed with an infection around the same time that this joint suddenly developed? And are you immunosuppressed? And pretty much any kind of infection can lead to a septic joint. So I've kind of put everything out there: pneumonia, urinary tract infections, having bacteria in the blood, having an indwelling catheter, cellulitis of the skin. And just know that your cultures may be negative when we take fluid out of the joint if you've already been on antibiotics. So this is the one where I'm going to say, don't try to treat this at home. This is the one you need to go to your doctor. If you've had a recent infection, you normally don't have joint pain, and suddenly one joint is very painful, very swollen, you're having a fever or anything like that, this is the time to call up your doctor and say, hey, I need to come in quickly. And if your primary says, by all means, come in the next 48 hours, great. If not, this is the one where I'd recommend going to an emergency room or an urgent care just to have it checked out, especially if you have a fever. And the reason we're so aggressive with infectious arthritis is because the joint can really be destroyed by the bacteria or the infection if it's allowed to go on untreated. And oftentimes, because we know this, we may recommend something called an orthopedic washout, where we actually go in to clean all of the infection out of the joint space. And I just threw on a couple of the other kinds of infectious or septic arthritises. So you can have gonorrhea can actually cause an arthritis. Sometimes people will have a stomach bug or a UTI, and that can cause an arthritis. There's very common viral arthritises, something called parvovirus or Fifth's disease, tuberculosis, which is extremely rare in the United States. And then probably the most commonly seen one in this area is Lyme disease. And that's usually kind of a slow, nagging buildup of one joint being involved. All right, and last but not least, should I see a doctor about this? When to know when to go for any of the other things that are not the infectious arthritis. So if you've had joint pain for 4 weeks Even if you can work around it, even if you're limping and you're getting through your day, but it's really just there constantly, come see us. If you have an infection, if you're on antibiotics and there's just one joint that's super painful, definitely come see us. If you've seen a tick on you and you're not sure how long it's been there, come to the primary doctor. We can screen you and potentially put you on antibiotics for possible Lyme disease. And if you notice that the joint pain was mild, going on for a little bit, maybe went away, but then all of a sudden it comes back and it's really bad, really far worse than it was before, or suddenly just one joint is really red, really warm, it feels like there may be fluid, you can't stand on a joint, definitely come to the doctor. And so who do you come to? So first, always start with your primary. They are the gatekeepers. They see everything. They know how to really triage and kind of start the differential to figure out what kind of arthritis do we think is going on, and they can really help guide you to which doctor you need to see, as well as start a workup so that by the time you get to see us, we have something to go on already. So oftentimes this will be blood tests and imaging. You may be offered physical therapy, which I usually is my first line too. So I would definitely recommend that if you're offered it, definitely try it because it doesn't have side effects. It's a very conservative therapy, and it oftentimes can do a really good job. And sometimes it's hard to get through physical therapy. It's high copays. You don't have time to do it. If you have access to the internet, go online, look up some home exercises, try to work those into your schedule. And if there's a concern for rheumatoid arthritis, psoriatic arthritis, gout, something like that, you may be referred to see a rheumatologist. And yes, we know that we have long waits, and sometimes it's very hard to wait that long, and you're worried, am I doing bad by my joints by waiting this long? Oftentimes, a few weeks isn't going to change anything. It's not going to create any irreversible or permanent damage. But I definitely recommend you asking your primary, hey, what can I do while I wait to see the specialist? And that's it. So thank you very much for having me to give you this talk. I really want to thank Assemblywoman Marissa Miller and the Oceanside Library. And I want to thank Dr. Diane Horowitz, who basically put me in touch and set me up for this. If anybody has questions, we'll put the questions in the chat box and I'll try to answer as many of them as I can.
Okay, great. Thank you, Dr. Lobo. So I'm going to stop the recording now. And Chris, when you're ready, you can start the questions, but I'll stop the recording right now.